Thank you for viewing the North Dakota Department of Human Services Behavioral Health Division's online training for withdrawal management during the COVID-19 pandemic. Our presenter, Marvis Doster, is a certified addictions registered nurse with over 40 years of experience working in addiction treatment programs. Currently, she is a technology transfer specialist with the Opioid Response Network in association with the Mountain Plains Addiction Technology Transfer Center at the University of North Dakota. Marvis has been a national trainer for screening, brief intervention and referral to treatment, telehealth, medication-assisted therapy, ASAM placement criteria, and compassion fatigue, as well as many years as the trainer for social setting detoxification throughout the state. Thank you, Marvis. I'll hand it over to you.
Thank you. I am very honored, actually, to be able to talk about the withdrawal management, because it is probably the thing that's nearest and dearest to my heart as an addiction nurse. And with the advent of the COVID-19 pandemic and the impact that has had on special populations in our state, I was very pleased to be asked to help in this way. So this training really is to focus on the hotel shelter undertaking, I guess, that's going on to really focus on very vulnerable populations who are COVID-19 positive, to give them some support and safety and security in a site that is being managed by people who are understanding of their particular concerns and of COVID-19, as well as the possibility of the complications of withdrawal management. Many of the people in the population that we're serving have a history of substance use problems and have also mental health issues that can complicate the care of COVID-19 positive or symptomology. So that is why we're talking about withdrawal management, to bring to the forefront the possibilities that staff who are working with this population in hotel shelters might face. So truly, it's a review of the concerns that we all have about withdrawal from substances, and to remind ourselves of the symptomology that we might see and how that can be impacted by an infection and a process such as COVID-19 that is affecting someone with these underlying health issues and chronic illnesses as well. So the next slide, please. Withdrawal management truly is a set of interventions that are used to look at managing someone who may be acutely intoxicated with alcohol or with any other substances, and the withdrawal that the body goes through to come back to a normalized state. Withdrawal management really wants to minimize what the physical harm is, minimize the physical harm that can be caused by the abuse of substances and what happens to the body and the brain and the behavior as a result of someone being in acute withdrawal. Withdrawal management alone, of course, is not sufficient for treatment and rehabilitation of substance use disorders. And we always work with people in having withdrawal symptoms towards seeking recovery resources in other areas as well. So once they're stabilized physically with the withdrawal that they might be experiencing, and also with the COVID symptoms that are of concern right now too, that we might lead them towards seeking help in other ways as well. Sometimes when you reach a crisis in your life like this, it does move us towards making changes. And this might be just a golden opportunity for us to really help people find their way to recovery as well. The next slide, please. So the process of withdrawal management is really to evaluate people, and that's truly what we're going to do in hotel sheltering, is evaluate them, to monitor them for the COVID-19 symptoms, as well as monitoring for symptoms of withdrawal. And then we want to really stabilize people and foster their readiness into treatment. Next slide, please. The principles of care during withdrawal is that we need to remember that there is not a cure, the kind of an old terminology for substance use disorders, but it's often really this first step towards recovery. Substance use disorders are treatable. We need to remember that they respond very, very well to treatment services. There's hope for recovery for people. Substance use disorders are brain disorders. They're not evidence of a moral weakness. And the thing that I would like to remind people to keep uppermost in their minds is how important it is to treat this very vulnerable population with respect and with dignity at all times in the things that we're doing and the support and the assessments that we are offering people at this time. Patients really need to be treated in a non-judgmental and very supportive manner. Many of the people I think that are willing and coming to the rescue really by working with this population, and for people who have not had regular contact with them, this presents a very, very interesting challenge. The people in this population are very vulnerable. They are very, very rewarding to work with, but they do present very interesting challenges. The challenge is to remember that they have, they're at a real crisis in their lives, that they're frightened, that they're in a situation where that's unfamiliar to them, and that in itself causes anxiety, and then the anxiety that goes along with the pandemic issues that we're facing, as well as being cut off from their usual means of managing these feelings and these symptoms, alcohol or other substances. Next slide, please. This is truly just a review of how alcohol is processed in the body, and how when people may come into shelter who are under the influence of alcohol, that it takes a while for alcohol to be processed. Next slide, please. The next few slides are really just to look at the level of intoxication that you might see, because you'll do a breathalyzer test, or they'll be monitored to look at what their alcohol level is. That will be assessed. And we look at, as the level increases in people, the more significant, of course, the impact there is on their behavior and on their physical symptoms. So this is just as the level starts to rise, and the next slide you can do too, just pass through this. I'm not going to go through each level, but just to give you some information about these levels. And the thing about alcohol is that people who are dependent on alcohol develop a tolerance to it, and so they can reach levels of alcohol that are stunning to the general population. And sometimes for people who are assessed as they enter treatment programs or as they enter emergency departments, people are stunned that they have such high levels of alcohol in their system, yet are responding appropriately and don't have the usual signs of alcohol intoxication. So these are just some reminders of what symptoms that you can see. The thing about alcohol is that even in people who are veteran users of alcohol can still reach a point where alcohol can cause death, where there is a serious decrease in all of the vital signs. People stop breathing, their heart stops, and there is a lethal level of alcohol, no matter if you're a novice user or a veteran. Next slide, please. The patients that we'll be seeing in the hotel shelters have been assessed, and they have had a medical assessment. They have been seen by either their primary care provider, or in an emergency department, or in another program that is referring someone to hotel shelter. But they've had a general health history, and their mental status has been assessed. There's just been a general physical assessment. Vital signs have been monitored, and there also have been information gathered about their substance abuse history. They may have had a urine or a toxology screen for common substances, and there's also been a history requested about their past substance use treatments and past withdrawal management. So they're in the forms that we're using and the assessments that we're using. These things will have been asked and determined at the time of referral to the program. Next slide, please. The assessment tools that we'll be using in the shelters have been around a very long time and are very well known to the people who work with this population on a regular basis in shelters, in detox centers, in emergency departments throughout the state, in treatment programs where there's social setting detox being done in treatment programs. So the tools are well known. If you're not really familiar with them, they're very easy to use, and it just becomes a part of your assessment of the patients that you will be caring for in the hotel shelter. So the CWA is the Clinical Institute of Withdrawal Assessment, and AR means just alcohol revised. It has been around for a very long time, and it's been revised to just updated through through the years it has. And the COWS is a clinical opioid withdrawal scale, and that is specifically for opiate withdrawal, which I'd like to just mention as well. Some of the things to look for. Many of the population that we serve have a particular preference for a substance. It might be alcohol, it might be opioids, it might be methamphetamine or marijuana. It could be a multiple, but many of our clients have multiple substance use and may have a particular favorite, but will use multiple substances or whatever might be available to them. So we'll look at just some of the symptoms to look for in some of those other substances of abuse, but primarily alcohol will be of the greatest concern. Alcohol withdrawal is still by far the most significant and life-threatening withdrawal that we deal with in the medical profession and in this chronic illness. And alcohol withdrawal puts a significant stress on the body. And when you add an active infectious process like COVID-19, it can significantly impact the response that people have to alcohol withdrawal. And the patients themselves will give us a really great history of what their withdrawal is like. They're probably very well aware of what a CWA is, and they've been utilized in the past in managing withdrawal with them. And they may be very well aware of what their withdrawal is normally like. The thing about the illness is that it progresses, and withdrawal becomes significantly worse in people the longer that they have a dependence on alcohol. And the other thing is that the unknown with an infection going on in the body and a positive COVID-19 test, which could complicate this, and they may not be aware of that. So part of your education with them is to let them know that why you're assessing them and why you're using these assessments and monitoring for withdrawal is because of that, is because of the impact that it can have. So there might be other drug testing options and other tests that might have been done that you would have the information available with. Depending on the site that you're at, and what you're doing, this is, just assessment a site. So it just depends on from place to place, I guess, what's available and what information you'll have available. Next slide, please. This is kind of hard to read, and hopefully you'll be given a CWA that's much easier to read than this, but this is in essence the assessment factors on a CWA. And as I said, it's been around a very long time. It has very observable symptoms that we're looking for when we are assessing. So you do vital signs with the patient, and then you ask these questions and look for changes in their physical and mental status that can be related to alcohol withdrawal. So these factors are very common symptoms of withdrawal, and the scoring is on a scale of 0, meaning there are no symptoms at all, or the patient reports none, and you observe none, up to a 7. And the reason it's a 0 to 7, and there might not even be some words or some descriptors in like in nausea and vomiting, for instance, there is a scale of 0 to 7, but just there's just descriptors on 1, 4, and 7. So you ask somebody if they're nauseated, if they're feeling nauseated, but there's not been any vomiting, that could score a 1. The next time you talk to them, they might say, boy, I'm feeling a little more nauseated. I haven't vomited yet, but I just feel really sick to my stomach, and I just feel like I'm going through this. So they have an increase in their symptoms. So you have an opportunity to score on a scale of 0 to 7 to show just a minor change or a minor improvement. And what we're really looking for in the CWA is that. Are they improving? Are their symptoms improving? Are they progressively getting worse or progressively getting better? So that's why you have this that number 7 would be, extreme nausea and vomiting, dry heaving, and that they're not even able to stop or to it's kind of constant nausea and vomiting. So the other factors of assessment are tremor. And the best way to assess a tremor is to ask your patient to put their arms straight out, arms extended with their fingers apart. That is the best way to assess a tremor. Sometimes people who have a tendency to tremor try to hide it. They keep their hands close to their body. They keep them under a table. They are very uncomfortable, like drinking something out of a cup in front of somebody because they have such a significant tremor. So that's really the best way to assess. And if it becomes a part of assessment, it's really the best way to do that. So tremor can be not present at all up to a 7, which would be even with their arms at rest. Their full body sometimes has a tremor. They're just shaking from their head to their toe, and just unable to stop the tremor. So it'd be somewhere in between there that you would assess that. Sweating is also very common. A 0 would be no evidence sweat. Then you move to barely perceptible sweating, or their palms are sweaty or moist, and all the way up to a 7, which is drenching sweats, which you see sometimes in alcohol withdrawal in the later stages, where people are just soaking their night clothes and their sheets and their bed clothes, that they're just and a very huge concern if somebody is not taking fluids by mouth and not tolerating fluids by mouth, that those drenching sweats can really upset the electrolyte balance in the human body, and that can be a significant issue with that kind of loss of fluids. Anxiety is, you can ask a person how they're feeling. If they're anxious, are you feeling anxious or nervous? Let them describe it to you. And in subsequent assessments, they might say, oh, I'm feeling better. I feel more comfortable here. Initially, they might be quite anxious, or until they develop a rapport with you. Or if you're asking these questions in full protective garb, it might be take a while for somebody to develop a rapport with you. Things are different in the situation that you're in. So it just sometimes takes anxiety and agitation, probably pretty common response to the situation. And agitation means that they have pretty normal activity as a 0, up to a point where they're pacing back and forth. They're so agitated they can't sit still. They can't interact well in a conversation with you because they're just feeling so agitated. So the other assessment factors here are to see how people are responding to tactile disturbances, things in their environment, auditory and visual disturbances. One of the signs of acute withdrawal from alcohol is disturbances in these areas. People have heightened senses, heightened to things that are around them, things that touch their skin, things they hear, things that they see, and many times they can misinterpret what's going on in the environment around them. It can progress to the most significant thing, where they have uncontrollable kind of hallucination. They don't respond to redirection or support or presenting reality to them, but their visual disturbances become increasingly severe. In mild withdrawal, you often see people that have, that they're itchy, they're very sensitive to sound, they're very sensitive to light, and to things going on in the environment around them. They hear people laughing or hear other voices. They might misinterpret those. Those are pretty common in acute withdrawal, even in mild symptoms. But when they progress beyond that, that's what you're really assessing for. And again, that's on a scale of 0 to 7. Then you ask people about headache, not dizziness, but pain in their head, which is also a very common symptom of withdrawal. And it's on a scale of 0, again, up to extremely severe, where it's not responding to any comfort measures or over-the-counter pain medication or whatever might be available to help them. It is significant. Then you ask them, this is the clouding of their sensorium or their orientation to things going around them. You ask them what day it is, where are you, who am I, and ask them questions like that to determine whether or not they're oriented to place, person, time, and then you score that accordingly. So after you've asked the questions, scored that, you add up the score and determine where that person is at. Now the scoring with the CWA determines what kind of referral you might make. There's lots of different ways to offer detoxification or withdrawal management to people in alcohol withdrawal. Most people can be successfully managed on an outpatient basis or in a residential program that offers social, non-medical kind of setting. And most people respond to support, good nutrition, extra fluids, rest, and just an attitude or a presentation of a safe and secure environment, and one that is non-judgmental and very supportive. So most people respond to that. But what we're watching for in the CWA is people who advance beyond that, beyond the safe way that we can manage them in a social, non-medical detox setting. So the scores we'll talk about in a bit. I could have the next slide, please. So just to mention about the CWA too, that this can be used by non-medical support staff as well. And many people who work in a residential program or are support staff to medical professionals can do these CWAs, can do these ongoing assessments, can learn them and do them really well, and then report them. So it's been utilized by trained and paraprofessionals as well. So it's based on, as I said, observable signs and symptoms of withdrawal, but also reports from patients. It's not copyrighted and can be used freely. I've seen many programs that have adapted it in one way or another to be used for other drug withdrawal or for adolescents or for other special populations, some even for the elderly. So it is, different kinds of populations that it's been utilized for. Next slide, please. The triage process then is to determine what the CWA score and what is helpful in determining where a patient should be referred for services. In the shelter, in the hotel shelters, and in other shelters that provide social detox, patients have to score at 8 or below in order to be admitted to a social setting detox, social non-medical detox. So if their score is 8 or above, they need to have a medical assessment prior to admission to the hotel shelter site or to any other type of residential social setting detox program. But patients above that need acute medical care. And that is by state licensure, and it's the state that sets these parameters. So next slide, please. And these are signs and symptoms that require referral to an acute care facility. So if a patient has a CWA that's at 8 or below, they've been admitted to the shelter, these are the things that you would want to refer someone for if they develop problems like this in the shelter, or if they've had a history. We'll talk about that as well too. If a patient has a seizure can be common in some people in alcohol withdrawal, also unexpected seizures can occur, but someone who has had a history of a seizure disorder, you might expect more likely that each time they go through withdrawal, they may experience seizure. And sometimes the best way to treat that is to, to treat it in advance to prevent seizure from happening in a medical setting. Aspiration, if somebody vomits and aspirates their vomit into their lung, that is something that needs to be immediately assessed. Gross hallucinations or disorientation where people cannot be redirected or managed in a social setting needs to be referred. Anybody with difficulty breathing, and certainly with COVID positive patients as well, breathing is something we're going to be very much aware of and monitoring much more closely than because of the nature of the virus itself and the impact that it has on the lungs and on breathing. Any cardiac symptoms, patients who complain of chest pain, need to be assessed. High blood alcohol concentrations, the level for the hotel shelter is 0.25 BAC. Anything above that needs to have a medical clearance, and they won't be accepted into the shelter with a blood alcohol level concentration higher than 0.25. Pain or trauma, bleeding, signs of shock, someone who lapses into unconsciousness, any kind of uncontrollable behavior or uncontrolled behavior within the shelter, and people who are actively suicidal or make homicidal threats need to be referred for assessment outside of the shelter site. Next slide, please. So initially, the questions that are asked, and sometimes in developing a rapport with somebody to really get an idea of the kind of withdrawal you might expect, is that you make sure that it's alcohol that's responsible for their condition, or if there are other substances involved. How long have they been drinking up to the time they come to the shelter? What time did they last drink? How much? And because sometimes people might come in with an appropriate blood alcohol concentration, but if they've onboarded a lot of alcohol just prior to their admission, their level could start to go up. What is their history of drinking? What medications are they taking currently? That'll also be included in the initial assessment. History of chronic illnesses, and then have they had any recent injuries or falls or been involved in a fight where they might have been injured? And do they have any other immediate medical or physical concerns that they want to relate to you? So those kinds of questions are the kinds of things that you might talk about in your initial conversations with people. So the factors that might estimate how severe alcohol withdrawal is going to be is how frequently are they using, how much alcohol do they consume, what is their age. The more advanced their age is, the more likely they are to have more significant symptoms. What has their previous withdrawal history been? That's the best source of information, is when patients tell you what it's been like for them before. Were they hospitalized? How did they manage their withdrawal? What have they been, in other social settings, and have them describe that to you. What are their eating and living habits? Many of these patients are homeless, have no other place to shelter or to be monitored for their positive COVID. So they probably have been, in pretty dire situations as a result of their homelessness. Malnutrition, very common with them. And then the use of other drugs, as I've mentioned, and any other medical issues. And the infection, especially with COVID, how this significantly can impact withdrawal and the management of withdrawal. Next slide, please. So as I mentioned, these are the symptoms of withdrawal that we've gone through on the CWA. Generally, the signs and symptoms can start within 6 to 24 hours after a person takes their last drink. So you might not see symptoms develop until someone has been without alcohol for up to 24 hours. But for many people with chronic alcohol problems, sometimes even when they have a high blood alcohol concentration, you're already seeing signs of withdrawal as their blood alcohol starts to drop, because people tend to drink to maintain a blood alcohol level. And even though they might still be, intoxicated based on their level of alcohol in their system, they still could be showing signs of withdrawal. Next slide, please. So in the next 3 slides, this is just a look at mild, moderate, and severe alcohol withdrawal. And sometimes it's easier to think about it in that way, that people might have with mild symptoms, shakes, and their blood pressure and pulse can be quite elevated. They have anxiety, they're irritable, they have a decreased appetite, they don't sleep very well, and then they have this visual and hearing hypersensitivity. Most people don't progress beyond a day or 2 and then the symptoms resolve. Next slide, please. And when you move to moderate, people have those same kinds of symptoms of withdrawal, but they are more significant. Move the neck to there you go. And the severity that we see increasing most commonly then is with confusion and then with hallucination. Generally, these people require close observation and some medical interventions to stabilize them and to see them through these moderate. And then the severe symptoms in the next slide, please, are all of those symptoms, but with increasing severity. Extreme disorientation, paranoia, outbursts of irrational kind of thinking and potentially kind of harmful behavior to themselves or others. Their vital signs are significantly elevated. Respirations are affected. Sometimes they're really hyperventilating. They may develop a spike in their body temperature or fever. So, and now we have patients with an infection process possibly in their systems, and fever would be a significant symptom of either the withdrawal or the positive COVID. Sweat and vomiting and diarrhea, as I've mentioned, and that can result in significant dehydration, possible seizures. So this is the life-threatening condition. This is when people really need intensive hospital care in order to see them safely through this. A percentage of population, a small percentage with good medical care, don't have any long-term problems as a result of going through withdrawal like this with good medical care, but it is life-threatening. People do die of alcohol withdrawal. Next slides, please. So patients who have extreme forms of withdrawal need medical care. Patients who are in withdrawal and already demonstrating moderate symptoms of withdrawal require immediate medical care. And patients who might still be intoxicated but have only been abstinent, I said, even a few hours, have already had withdrawal symptoms or of an advanced age or have a previous history of very severe withdrawal also should be medically monitored. Decisions about treatment should be monitored, and a step down out of medical treatment should be monitored and discussed with the hospital staff. So as I said, withdrawal can be managed in many settings and very well, but it is it really depends on the presentation of that patient. So any temperature above in the data, this is from the licensing data, but any temperature above 100 needs to be referred is 97 to 100 is appropriate. Anything above that needs to be referred. Abnormal breathing, hyperventilation of more than 26 times a minute, but abnormal breathing can also be, in many other different ways, not just the number of respirations a minute, but people struggling to breathe and not feeling like they're exchanging air when they're breathing and becoming increasingly anxious and that sort of thing in regards to the coronavirus. Elevated pulse above 120 need to be are not appropriate for a social setting detox, and a blood pressure elevation of 160 over 120 or above is considered a need for medical intervention. Next slide, please. So the way patients are treated for alcohol withdrawal is primarily benzodiazepines like Librium, Valium, Ativan, Xanax, those kind of medications that will stabilize withdrawal symptoms. They're meant to be used just in a short period of time. Many of the patients that you might encounter here have likely been treated with benzodiazepines in the past. They tend to be a drug of abuse for people who've had multiple introductions to benzodiazepines for management of withdrawal. So that might be a consideration as well. That might be one of the drugs of abuse that's available to them. But sometimes they're given a loading dose, they stabilize really well and then can be referred once they have stabilized in medical care back into a social setting where they are stabilized on the medication and can continue on medication and receive medications over a period of time in social setting detox as well over a gradual taper, and then they have a very successful withdrawal. Other medications sometimes used are barbiturates or anticonvulsants to ward off seizures. Beta blockers or medications used for treatment of hypertension or high blood pressure, antipsychotic medications, and sometimes relapse prevention agents like antabuse. But although somebody with active withdrawal is not necessarily prescribed medications of that nature early in withdrawal. Next slide, please. So delirium and seizures are handled in hospital settings, and these severe symptoms are unmanageable in social setting and should be treated in a medical setting. Next slide, please. So Wernicke and Korsakoff syndromes are common problems related to actually vitamin deficiency in people with chronic alcohol problems. But you might see this with long-term or with chronic users of alcohol: confusion, muscle weakness, an eye muscle changes, loss of muscle coordination, so they have difficulty walking. And Korsakoff syndrome, they might have amnesia, profound deficit in new learning, and even in remote memory. And so sometimes responses that you get from people sound plausible, but are usually confabulated or made up to sound like they have a good memory or understand what you're telling them. But sometimes repetitive kinds of direction are really necessary with people who have this kind of neurological deficit from alcohol, but both related to thiamine deficiency. Next slide, please. So we've talked about the things that require immediate medical attention, and respiratory distress by far most important thing with patients with a positive COVID. Increasing symptoms of respiratory distress are imperative to watch for. Next slide, please. So also mental health needs, patients who are acutely suicidal or make homicidal threats, people who are very angry and aggressive and can't be managed in a social setting need referral for management of those symptoms, either with medication or with restraint or with interventions that will support them through that. Next slide, please. So we'll do a switch to a discussion about opioid intoxication. Patients who might have ingested opioids prior to coming to the shelter would show these kinds of symptoms of opioid intoxication: a very slow pulse, low blood pressure, low body temperatures. They look sedated. They don't always respond to verbal direction or questions. Their pupils under the influence of an opioid are pinpoint. So you look at their pupils and see that they are very small and don't often react to light or changes of light in a room, which you would expect. Their movements are slow. Their speech is slow. They might be nodding off and sleeping and can be aroused when you talk with them, but they fall back to sleep. They might have a sense of euphoria, look of euphoria about them, and they have pain-killing effects, so they're very much not sensitive to pain, and a calmness about them. So those are signs of intoxication. Next slide, please. And so those signs of intoxication, we want to watch to look for signs of over-medication that can progress to overdose. That's why we're watching those signs of intoxication. So they may progress to unusual sleepiness or drowsiness that you can't rouse them from. They're mentally confused, their speech is slurred, or they're not speaking at all. They have very intoxicated looking behavior. Their breathing becomes very slow, and very shallow. Their pupils are still very pinpoint. Their heartbeat slows, their blood pressure continues to decline, and you have difficulty rousing that person from sleep. They just don't respond to that. Next slide, please. So the signs of withdrawal then, or a narcotic overdose, is they're pale and clammy to touch, their body's limp, their fingernails or lips have a blue or purple cast around them. They may be vomiting or making gurgling noises where they might have vomited and aspirated. You can't waken them. Their breathing is very slow, or they've stopped, or their heartbeat is very slow or has stopped. So these are signs of narcotic overdose. Next slide, please. And the management of that overdose is done with Narcan, and Narcan will be available in the hotel shelters. Its use is simple to learn, and most people who work in the site here, the nursing staff, the people who work in our residential program, have been trained on the use of Narcan, and it is available there. But Narcan is used a nasal spray, and the recovery position, if you utilize it, you use Narcan and call for 911 for emergency assistance. But you use the Narcan and put people in recovery position and support them until first responders can get there. Next slide, please. So signs of withdrawal from opioids are exactly the opposite of the signs of intoxication. Their pulse, everything speeds up. Pulse is up, blood pressure is higher, body temperature goes up. They have trouble sleeping. Their pupils are now very enlarged in withdrawal, kind of fill their eyes. They have heightened reflexes. They sweat. They have goose flesh. They have an increase in their respiratory rate because they're so anxious. They cry. They yawn, their nose runs, they have muscle spasms and abdominal cramps, nausea and vomiting, diarrhea, bone and muscle aches, and extreme anxiety. They just feel miserable. This is a miserable withdrawal, and it is why people avoid stopping opioids, because of the nature of the withdrawal that they're in and how serious this is and how horrible it feels. So this is the COWS score. This assesses exactly those symptoms on a scale of 0 to 4, or some of them 0 to 5 in others, but these are observable symptoms. You again do vital sign monitoring. And if a person reports a history of opioid withdrawal, generally they can be managed in a social setting between mild and moderate symptoms. They can, but generally, there are medicines available to help people in acute withdrawal from opioids that can significantly reduce these symptoms almost immediately with the use of buprenorphine medication. For many years, we didn't have medication to really treat opioid withdrawal, and so it really had a very high rate of relapse with opioid users because of that. Next slide, please. So again, you just do those, you assess those symptoms, you note the score, and utilizing that is to utilize those symptoms to see if the patient is responding, are they becoming worse or showing signs of improvement as they go through withdrawal. Next slide, please. So again, mild, moderate, and severe scores there. It was also on the scale page. We'll just go to the next slide, please. So this generally people tend to look at opioid withdrawal as uncomplicated or not life-threatening medically. But the thing is that patients feel so overwhelmed. They can't wait for the cessation of symptoms because it can take, for some people, up to weeks of symptoms like that. So most prefer to end that by using again. And many times people start out using where they left off rather than building up a tolerance to opioids again. And so there's a high rate of relapse and then overdose and death when people return to use after a period of abstinence. Next slide, please. So the other medicines that are used to manage opioid withdrawal are clonidine, which is a blood pressure medicine that's been used for a long time to manage opioid withdrawal. About half of the symptoms are a reduction of about half, where they become a little more bearable to the person who is experiencing them. Methadone is available, but in DEA-controlled opioid treatment programs. There are several throughout the state of North Dakota, and you may have patients in your site that are on methadone or on buprenorphine or Suboxone, which is the other medication used for management of opioid withdrawal. Next slides, please. So other substances that can present withdrawal symptoms, benzodiazepines, as I mentioned, and other sedative hypnotic drugs that are prescribed for sleep or insomnia can have significant withdrawal as well. So if a patient has a history of benzodiazepine use or other sedative use, that is, their symptoms are very similar to alcohol withdrawal. Cocaine and methamphetamine we'll talk about in a bit in a little more detail. Inhalants and solvents generally have symptoms of kidney function problems and disorientation and memory issues. People who have been using inhalants. Steroids, people generally are very anxious, agitated, angry. It's a lot of behavioral kinds of symptoms rather than physical ones. And other hallucinogens and other drugs don't have perceivable withdrawal symptoms, but just a return to normalcy or return to lucidity in their situation or their behavior and their response to the environment. And nicotine withdrawal may be common too, depending on what the use of nicotine is allowed in hotel shelters. I would think that there is none allowed. It's my thought, but so people who are regular nicotine users may also be having withdrawal from nicotine, which is also very miserable for people who are regular nicotine users. Next slide, please. Just want to talk a bit briefly about methamphetamine withdrawal, which is generally such strong craving is probably the most difficult thing that people deal with, but they're lethargic, they're depressed, they have significant body aches all the way to their bones is the way they describe it. Certainly changes in appetite and weight. They've probably not been eating very well. Their appetite is voracious when they are coming off of methamphetamine. Eat, because they've been starving generally if they're using methamphetamine regularly. Certainly change in sleep habits. Initially, they sleep all the time, and it's just the body's way of recovering. Sleep. But then after they're through that initial sleeping and for a day or two, then they have insomnia and problems going to sleep and establishing sleep habits. And this is usually quite a long period of recovery, but initially those are the most significant symptoms that you'd see. Next slide, please. Marijuana withdrawal has its list of symptoms as well. Likely, most common ones are insomnia and headache, probably the two most common symptoms with marijuana withdrawal, but also very vivid dreams and nightmares and a lot of anxiety and a loss of sense of humor, loss of concentration and learning, which improves over time. Next slide, please. Just a few more symptoms with marijuana. Night sweats and body odor from the night sweating. Productive cough is pretty common too if people stop using. stop smoking marijuana, they develop a productive cough as they're clearing their lungs. Some people also report dizziness and body aches, and they're a little more prone to infections. So patients that you might see who've been regular marijuana users who are COVID positive, that's why we'd monitor them for symptomology. Chronic fatigue also very common in marijuana withdrawal. Next slide, please. So the things I just want to mention in social detox that are really important for people who are experiencing some mild to moderate withdrawal is that you provide a setting that is non-threatening, very positive, comfortable. Be aware of the lights and the sounds and the contacts that they have with staff. And if you're using masks and you're gloved and covered with protective gear, to remember that is that's a barrier in itself to developing rapport. So as you're working with this population, it is that step and that reason is another challenge for you. Keep patients involved in purposeful activity if you can. If in withdrawal, if they're just sitting around and not talking, not engaged, not doing something, it becomes worse. Good hydration is really important no matter what the withdrawal. So good night nutrition, also important. Encourage people to sleep and to rest. Their bodies need a lot of rest. And people who are COVID positive, as you're monitoring for symptoms, the better they rest, the better that is. So reassurance of recovery, a reality orientation, which means, really educating people on what they can anticipate and what they can expect in withdrawal is important. And then treating people with respect and with dignity, as I've mentioned. I just can't say that enough. That is so important. Many times when this very vulnerable population has had multiple admissions to ER, to hospitals, to residential programs, the staff is they're very well known to the staff working with them in those kind of situations, and they know a lot about their history. They've had history with them and already have established a rapport, so can help you as a new staff to feel comfortable in the situation and comfortable with them. They're very good models for that. So that respect and that understanding, you can learn a lot from them. They can tell you a lot about their history and where they're at, what their history of withdrawal has been and their chronic symptoms. So I'd really encourage that. Communicate with caring and with a willingness to help them. And somebody who might be abusive or violent or acting out a bit, sometimes your calmness will just calm them down. I talked about some people who are uncontrollable in their behavior, need a referral, but otherwise you can offer a lot of support and de-escalation by just your own behavior. But to recall that you should be aware of the exits in a room. Don't place yourself at any kind of disadvantage. Be aware of objects that could be used as a weapon in an environment, just to have an awareness of what's going on around you. Really just decrease the stimulation. Quiet and supportive care, really important. So your personal safety is very important, and the safety of your coworkers and other clients, and the well-being of your client in situations like this. So know what to do in an emergency situation. If you're new to the site, know where the information, there's lots of resources that have been left at each of the hotel sites to make sure that you have a follow through about emergency situations and who to contact in an emergency. Discuss that with your coworkers and with others who you are working with who have probably a good understanding of that process. So educate the withdrawal process, use your support systems, the other people that are working there who are very familiar with this population. Be sure you maintain a drug-free environment, that if you're concerned that someone might have alcohol with them or other substances with them, that you address that. Consider alternative approaches that you might use to someone if they're uncomfortable or what might make them more comfortable. And motivational interviewing or motivational kind of approach is really important. But the most important thing, I think, is fostering a therapeutic alliance with your patients, with making sure that they know what you're doing and why. The CWAS should be done every 4 hours unless you are really concerned about something. You can do it as frequently as you want to see if people are progressing, or if you're concerned about their symptoms, or if they're sleeping, you shouldn't wait any longer than 8 hours to do between CWAS to assess somebody if you're concerned about recent use and possible withdrawal. Documentation, also very important. Concise records are really vital. Include details in verbal and written form and reports to others that can utilize the care when you have an oncoming staff, or you're transferring the care to someone else, that you really give a good report about that patient, what their status is, and what you've seen and what you've observed. And also, if you're transferring someone to care to a facility outside of the hotel shelter, if you're referring someone by ambulance or to an ER, that you contact them with information, that you let them know that they are COVID positive and what you're concerned about, and that they can prepare for that. So the transferring medical professional should relay the information, and the patient's age and their history and medications they're currently taking, and the concerns that you have. So those are and documenting that is important as well. Next slide, please. So this is my contact information here in Fargo. If you're in Fargo, you need assistance, this is where I live, but I will be available for any kind of overnight or weekend on-call information or support for patients who are in acute withdrawal that you might have questions about. Always happy to answer any questions or give you any kind of support I can in situations like this. So that's my email contact and my cell number. Please contact me if you do have questions. Thanks so much.